The most important part of the examination is to make sure that you carefully wash your hands before approaching this baby, which I've already done. And the second thing is then to do a very cursory exam of the baby by just looking at the infant, evaluating whether or not the baby's in any distress or having any respiratory difficulties or has any gross abnormalities that are quite obvious initially. I like to examine, especially the final examination of the baby, in the presence of the parents so they can see all the things that I'm doing with the baby before they take the baby home. Now this baby here is very quiet, not looking around, so I'm not going to really do anything to disturb the infant. My first part of the examination is to look at the face, evaluate the ears, nose, mouth, to make sure there are no gross abnormalities, that the ears are normal, there are no clefts, and then I carefully examine the skull, the cranium, feeling for the anterior and posterior fontanelle, feeling if there are any ridges along the sutures, to make sure there's no evidence of cranial synostosis. After I've done that, I evaluate the neck to make sure there are no masses, and I will put my finger in the mouth just to see if this baby has a cleft palate. I've already ruled out a cleft lip. The baby has vigorous sucking capabilities. Now, some people will go to the chest. I usually examine the abdomen at this time, starting at the lower part of the abdomen, carefully examining to see if there's any evidence of splenic enlargement. And usually if the spleen is palpable, it's usually in the anterior axillary line as it comes down. This baby's spleen is normal. I also then try to feel to see if there's any kidney enlargement or if there are any masses. And then often I'll do the same thing on the right side, looking for enlargement of the liver, starting low down and working my way up. And at that time also seeing if there's any abnormalities in the area of the kidneys. So far everything looks good, making sure that there's no evidence of bladder enlargement or anything like that. I then, after I've done that examination, I listen to the heart and lungs, starting usually at the base of the heart. And working my way down along the left sternal border out to the apex, seeing if there are any murmurs. Usually the most common murmur is what we call an innocent murmur that's often heard here at the base of the heart, most often on the left, occasionally on the right, and then listening to the axilla to see if there's any evidence of the murmur that can be heard in these locations. Listening for the first heart sound to make sure that there's no splits, and then listening carefully for the second heart sound to make sure there's not a split second sound or evidence of a rumble or a gallop. I carefully examine the axilla to make sure that air exchange is equal on both sides, and then I turn the baby over to listen to the lungs in the back. This baby's very compliant. I still percuss to see if there's any difference in the sound. Very few people do this anymore. And then listen to make sure there's air entry equal on both sides, as in this baby case. Now, sometimes if a baby's having respiratory difficulties, you might hear decreased air entry even before you would hear the baby having growls. Now, when the baby's head is turned to the right, you will usually hear best breath sounds coming in on the opposite side. When you turn the baby's head to the other side, you will hear breath sounds entering this side more clearly than on this side. While the baby's on the abdomen, I carefully examine the back, make sure there's no sacral dimples or any other abnormalities noted here. After I do that, I turn the baby over. Okay. Sorry. And then I examine the baby's diaper area. If I could get it open. This is a little girl looking for abnormalities to make sure there isn't marked enlargement of the clitoris, that there are no abnormalities of the vaginal orifice, and then carefully examine the groin area to pick up femoral pulses, which baby has very nicely. Now, when the boys, especially if it's a preemie, it's important to search for herniae, because up to maybe 20 or plus % of very small preterm boys will have inguinal hernias. Usually the nurse will pick this up during their examination, let you know, but sometimes when you come back to examine the baby, they aren't there. So the next best thing is to try to feel for the spermatic cord in this area and roll your fingers over that. If there is thickening of the spermatic cord, you feel like a silk sign, feeling tissue rolling over tissue, which is a pretty good indication that there is an inguinal hernia. Of course, now with ultrasound, you can pick up those much easier than even a physical examination. At this time, I try to evaluate the baby's tone, lower extremities, if the baby has clonus. I usually don't do much of reflexes other than checking for tone and make sure there's adequate movement. At this time, I try to examine the hips, and in the small babies, it's quite easy. Just putting your fingers over the femoral heads and abducting. Many of the preterm infants who have been in the hospital for a long time may have very tight hip abductors, and then you may have to do more of the examination of pressing in on the, pressing down on the knees and trying to see if you can elicit dislocation or a click. We often find more evidence of tight hip abductors than we do find evidence of dislocation of the hip. Also, I forgot to mention, but looking at the back, you can see if there's asymmetry of the gluteal folds, and that would sometimes give you a hint that you might be dealing with hip dysplasia. At this time, I try to complete my neurological exam. We've already seen the baby has a good suck. Now I'm trying to see if the baby has a rooting reflex, which this baby does. I love to do this. That's where you press in on the palms, lift the baby's head. The baby's head will come to the midline and show the parents that this baby has excellent muscle tone and really strong little infant. And then the last part of the examination, if I could get this baby quiet, I try to do a quick ophthalmologic examination to make sure the baby has a normal red reflex. And this is what I ask the nurse to give me a hand, try to keep the eyes open while I do that. I'm not going to do it on this baby. I don't want to keep this baby open and out too long. And a good examination like that, if done even pretty carefully and not missing anything, should take between 3 to maybe 5 or 7 minutes. And that's all I do.